Hey everyone, welcome to another What's Up Doc Q&A with an amazing doctor who treats a disease more prevalent and deadlier than most cancers combined, known as peripheral artery disease. That's poor circulation in the legs. Well, this PA doctor actually has PAD as well and is gearing up for a procedure to open up his blocked arteries in his legs. And we're going to talk all about that in just a few moments. But let's say hello to Dr. Kevin Lurie from Alaska. Thank you so much for being here.
Good morning. It's an early morning here in Alaska. It's probably 5 degrees and a beautiful day. The sun's going to come up in an hour or two. So another
You're
day in
not from
paradise.
Alaska. You're not from Alaska. What brought you to Alaska?
Um, a work to set up a outpatient center in a vascular office here. So
Oh,
I
fantastic.
came out of here on a work contract about 7 years ago and fell in love with it,
Oh
and
my goodness.
so I stayed ever since.
And you're a general surgeon. What in
General and vascular surgery. Yeah. Mhm.
oh, general and vascular surgery.
Correct.
And so why are you doubling down on PAD as an interest for you and with your new outpatient facility?
There's a huge need for aggressive modern treatment for vascular disease to save limbs. And this is an area that's very underserved. We have lots of people who have had poor medical care or no medical care, and they live hundreds of miles from here and they come in for treatment. Um, the wilds of Alaska, like you see on television, is true. And the hospital I work at is called Matsu Regional Hospital, and the next hospital over is Fairbanks. So I'm not sure where in the world you are, but I think you're in San Francisco. Imagine
Yep.
that the next hospital was in LA.
Oh no.
So everybody between those hospitals will come to my hospital for care. All those people who live in the middle of nowhere, who live in dry cabins, who live on the other side of the glacier, who get around by dog sled and snow machine. They come to the hospital for care.
So many of these patients you wouldn't imagine are letting the dust settle beneath them. They're very active. What is it that increases a patient's risk up in Alaska, do you think, for PAD? Why is it so prevalent up there?
Well, smoking is very common here. A
Oh,
lot of people smoke, and medical care is very sparse. So people don't get good medical care, and the medical care that they've gotten for most of their years has not really been up to date. So their diabetes hasn't been well controlled. They smoke a lot. And yes, they're very active and they go out to the woodshed and gather their wood to feed their fire, to heat their home every day. And they go cut their wood. But they learn to take shorter walks. They walk their dogs every day, but they say, oh, I can't get to the mailbox anymore. Or I walk with a cane now to get to the mailbox. Or the dogs take me out to the mailbox. It's a different life up here.
and how long have you been focused on PAD compared to at what point were you diagnosed with PAD yourself?
Well, I mean, I've always taken care of peripheral arterial disease. And then a few years ago, I was skiing in the valley, one valley over, and I blew out my knee. And when I took knee X-rays, I saw all my vessels were calcified, and I said, "Well,
Oh
that
no.
shouldn't be that way. I
Oh,
eat right, I exercise, I don't eat red meats. I've been taking my cholesterol medicine for 25 years. How could that be?" And so subsequently, I was having lunch with a friend of mine who's a cardiologist, and I was telling them that story. He said, well, you should come see me in the office. And long story short, I ended up having coronary disease that got treated with stents. And I got much better in terms of my endurance and lifestyle. And then we changed the lipid management. And in lipid management, um, I changed from statins to Repatha.
right.
And that was a huge difference because my muscles stopped hurting. But then I realized, I can go for 3 or 4 or 5 minutes and then my left leg buckles. So it shouldn't be that way. So I said, okay, well, time to look into this and get it fixed. And I knew that I couldn't feel the pulses in my feet anymore, and that's not normal. So I looked into it and go ahead and get it fixed so I can do more.
That must have been frustrating to go, oh my gosh, how could I have prevented this? Is it possible? But when you have that genetic high cholesterol, that's pretty tough. And especially, I know that Repatha has been a newer drug on the market, and it has been ultra successful in helping patients like you, if only you had it sooner versus later.
I think that's true. I went to fancy doctors at Johns Hopkins, and that's not my lipid management's not my field of knowledge or field of specialty. I treated my high cholesterol the way they told me and very aggressively, but the LDL portion was never aggressively treated, and that seems to have been what bit me.
And when you injured your knee while skiing, had you experienced any symptoms prior to that? Was your leg bothering you prior to that, that you dismissed those symptoms as, that's just part of the statin. That's just part of getting older. Oh, I just have a regular leg cramp, even though you knew in treating PAD patients that maybe that's a symptom I should pay attention to.
Yeah, absolutely. I don't, in retrospect, was that the cause of my crash? I don't know. I've broken my limbs many times, so I just chalk it up to old sports injuries. Um, in the in November, I was visiting my daughter, and she walks a lot, and I couldn't keep up with her walking in the streets. And she'd say, "Come on, Dad, come on, come on." And I couldn't keep up, and I said, "That's not right. Hold on, I need to catch my, rest my legs for a minute." I said, "Oh, that's not right. It shouldn't be that way." So yeah, I mean, it doesn't have to be crippling. It just inhibits your lifestyle and stops you from doing the things that you want to do.
Yeah, and you have some pretty great hobbies, which, not only the glass blowing, right, at a pro museum level, but also you lead hiking groups.
Right. And so the groups that I lead out in this beautiful wilderness, I tend to take on level hikes, and I do what I call introductory easy level hikes so that people can stop and they can look, and I know that, if I get tired, I stop and take a picture. I say, "Oh, look at that over there," and, distract people, and that's the way people with leg cramps from whatever illness deal with their pain, is they learn to pause and stop and change their lifestyle a little bit. Um, and then it just gets progressive, and you say, "Wait a minute, I can't do the things I want to be able to do." And it's time to fix it.
It's interesting. I was just reading a study that I pulled up today on asymptomatic versus symptomatic patients, and I think it was Mary McDermott, a famous researcher for PAD, that came out and kind of made that distinction. And because it used to be that you would use typical claudication, right, to say, "Hey, this patient has PAD," but what if these patients aren't walking anymore? Maybe at some point they made a conscious decision that, you know what, or even subconscious, that, whoa, if I walk at that pace, I'm going to get a cramp. So I'm going to slow down. And it just becomes part of life. You're normal for you to walk at that slower pace. So when you go to the doctor asks you, do you have claudication when you walk? They say no. And it sounds like that's what happened to you, is you were saying, no, I don't have this claudication, but here you are, you have slowed down.
Correct. Yeah. And I was at the gym the other day, and because I wanted to quantify it a little bit. So I started off at 3 miles an hour at 2% grade or whatever it is. Like at 4 minutes, my left leg's buckling. So, okay, so I go to level. No, that doesn't fix it. Okay, go down to 2.5 miles an hour. Okay, go to 2 miles an hour. Okay, then it stops bothering me. Then I pause for a few minutes and resume. So yeah, it's very frustrating. It stops me from doing the things I want to be able to do.
Has this changed you experiencing what you have with PAD? We have patients that always say, I wish that a PAD doctor would understand what it's like to have PAD and the debilitating nature. You hear so many doctors that are out there, they just like walk, 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 and don't come back. If the pain gets so bad, we'll just go ahead and amputate. And you're thinking, well, walking through the pain just seems counterintuitive. And do you realize, doctor, the debilitating nature? Well, you know what it's like. How has that changed your approach or the conversation with your patients?
Well, I think that walking is an exercise, and stopping smoking is the initial treatment,
Mhm.
and diabetic control is the initial treatment. So I think that it's really important to get people active and moving. And many people will get to a level that they're comfortable if they get on a regular exercise program. The question is, what happens when you get on a regular exercise program and you're still plateaued out? Then you go and fix things. In general, my practice is weighted toward limb salvage. We see a lot of things that are way beyond just cramps when you walk. So I'm very aggressive about treating for limb salvage to prevent amputation, but also because of my own personal experience of just being able to do more when I feel better, I'm very aggressive about treating people to get them back to their lifestyle that they want. Here in Alaska, I see a lot of people who just have the same complaint that I have, which is I can't snowshoe anymore. I can't ski anymore. I can't hike anymore. And I'm perfectly happy to help get them back to where their baseline is. My colleagues in my office place are not willing to do that. They're just not, they're just say, well, just do the best you can. And whether that's age or experience related, I don't know. But then they complain to somebody and they say, oh, go see this guy, he'll fix you. And that's kind of what happens. I mean, there is a broad spectrum of good care, and those other people aren't wrong. That's just their style.
Right. But from experience, and I think that your experience with this is helping you to also provide earlier, more advanced treatment for these patients because you recognize the debilitating nature. And I think that that makes a huge difference. Do you agree?
Absolutely, for sure.
And we
And
have a couple
the
questions.
technology for treating this has just been phenomenally improved through time, so that we can be more aggressive and we can do safer procedures. And many of these procedures, almost all of them, are done as an outpatient now. You don't come in the hospital and stay overnight. You go into an outpatient center. You have a procedure that lasts for an hour or two or three. Stay there a couple hours longer and go home. And so that radically changes what we can offer people in terms of their treatment because the technology is better and the outpatient care is better.
And I'm curious if you wouldn't mind sharing where those blockages are that you are experiencing. And two, I wonder if these advances and which particular advances has made you say, okay, well, I think now's the time that I think that we have a more durable option here to fix my legs. So I'm going to go ahead and move forward with having an angiogram. Whereas maybe even a year ago, you might have said, I think I'm going to walk through a little bit more. I'm not sure that this is going to be worth my while.
So for me, my blockages are in typical places, which is above my knee, between my knee and my thigh, and then below the knee. And it's worse for me, it's worse on the left than the right, but I don't really know a reason why there should be a side preference. In terms of the technology, um, almost all the complications that we get in these procedures are when we go into a blood vessel and when we come out of the blood vessel. So that accessing the blood vessel using ultrasound, using much smaller needles than we used to use, is much safer. And then getting out, we have closure devices that close the little hole that gets made, and that prevents a lot of complications. Um, Historically, a lot of these procedures have been done by cardiologists that are not trained in doing peripheral work. That is, peripheral being the legs and the arms versus the heart. And because a lot of the technology is similar, people stretch beyond where they're trained to do procedures. And So a lot of the complications that I see on the surgical side of my practice are complications from other people doing the procedures. So I think that the answer is smaller needles for safer access, a little bit using ultrasound to get in is way safer. And then closure devices to get out uh, is definitely a safer option.
And, you did mention below the knee. There are a lot of your colleagues out there that still refuse to treat any vessels below the knee. But I'm assuming, they'll fix the faucet and they'll hope that the below the knee vessels will just automatically reperfuse, or there will be enough, blood flow turning on the faucet that, okay, well, now you just need to walk and we'll hope that those collaterals build below the knee. But in your case, you want to have continuity in your treatment. It seems, as you're heading to Hawaii, right? To one of your colleagues, a wonderful vascular surgeon at Oahu, Dr. Amer El-Sergani. Um, and so I want to hear, why you've selected, this particular venue, this particular surgeon, and what you're hoping for in terms of the tools and the techniques that might be available for you, that helped with your decision to say, I just treat the whole leg. I got to get back to my norm.
Sure. Uh, in my mindset, since the biggest dangers of these procedures are the access points, that is getting in and getting out. Once you're there, you should be as aggressive as possible. It's certainly true that the traditional treatment is to fix inflow and then fix outflow, to get more water into the house and then fix the faucet. If you fix the faucet and you're not getting water into the house, then it doesn't make any sense. But if you're already paying the plumber to get there, you might as well fix both at the same time. And so I just want both fixed at the same time because that's what makes sense to me. That's where if the highest danger is getting in and getting out, then the fewer times that people are there, that's better. In terms of the person I chose to do it, we can access these blood vessels in different places. So traditionally, when people have had a heart catheterization or a leg procedure, we access the blood vessel in the groin at the hip joint. That's called the femoral artery. And as technology improves, now lots of people get their procedures for their heart done through their wrist or through their arm. And in peripheral arterial disease, we access, we can come in through the arm, but the more sophisticated way and technically harder way is to come up from the foot, to access the blood vessels from the foot and then come up. And if you think about, if you have a bleeding problem, it's way safer to have that bleeding problem in your foot than to have it in the major blood vessels that go into your belly. And so Dr. El-Sergani is really good at what we call pedal access, accessing the blood vessels in the foot. And so I think he takes the same surgical endovascular approach that I take in patients. And I like that. I talked to some of my colleagues from Washington, D.C., where I used to practice. And even though they're very good on technology, they were kind of stuck on, well, no, let's just do this as several procedures. Let's fix your thigh first, and then we'll come back another day and fix your. And I was like, okay, well, that's not wrong. That's certainly
It's one
well
option.
within the spectrum of good care. That's just not what I want for me.
Isn't that interesting? It's something that I fight for every day. I always, exactly as you described, I see more and more complications these days with patients that no one bothers to check the outflow. They'll even do bypasses, which bypasses, I mean, I have patients that had bypasses 15, 20 years ago, and they're still going strong. But the bypasses that I'm seeing done today, I'm having complication after complication after complication. Two major reasons. Either one, they didn't check the inflow for a fem pop fem tib bypass. So it goes down because there's nothing coming in. I don't understand that one. But more frequently, no outflow. So they reattach below the knee, and the plumbing below that can't support the faucet being turned on. And you have some surgeons that will say, you know what, before any bypass, if I think it's a really going to be the most durable, I will still go in pedal. and actually see if I can eke a little bit more blood flow through there just to make sure that those tibial vessels, the ones, going towards the ankle, can support the additional, blood coming in, and it'll make the bypass last longer. But then there are other surgeons that say, "Oh, no, 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 I don't want to put those vessels at risk." And well, then why are you going to do the bypass anyway?
I think
Why
people
are
are
you
all
going to put the
trying to
patient?
do the best that they can within their skill set and within the ability of the hospital. So if you go to an urban hospital where there's fancy technology, you can have what's called a hybrid suite where you have an operating room plus an X-ray suite, and you can go in and look at those blood vessels, the tiny blood vessels, and they're small. They're the diameter of a big pen refill, or 2 millimeters across. They're small vessels, and you can go in and work on those in your hybrid suite under X-ray guidance. But most hospitals don't have that. Certainly in suburban America and rural America, we don't have those hybrid suites, and people are doing the best they can. But the skill sets and technology that's available in different parts of the country really dictates the sophistication that you can use in your procedures.
And what I heard from one cardiothoracic surgeon who is also now doing legs is he was saying that he loves the retractable stent that he now uses. Before he'll do a bypass, he'll go in and do a little bit of that with the spur technology because he's like, it's great. I don't have to ruin the landing zone. I don't have to place a regular stent, and I can just eke a little bit more open to give that blood a little bit extra flow. So I thought that was kind of interesting.
Right. When we open up blood vessels, we want to allow for the next. It's like billiards. You want to set up for the next step, and so um, you said something interesting about the historical changes in vascular surgery. So 15, 20 years ago, we didn't have the sophisticated technology to cross blockages like I have. And so people would commonly get surgical bypasses for shorter blockages because that was state of the art. Now, as the technology has changed and people can be more aggressive in terms of thigh angioplasty, opening up these blood vessels in the thigh, then you don't need the shorter bypasses anymore. And the longer bypasses are technically harder and they're more complicated and they're very tedious. And you go into way smaller blood vessels. And so they have a higher failure rate, they have a lower success rate. The more aggressive you can be in terms of your angioplasty before that generally does help. And, but I think most people are doing their best within the constraints of what they have at their hospital and in their training and culture. Um, I certainly see, just like we see a political spectrum in the United States, there's a quality spectrum when you go from urban America to rural America. Uh, People who choose to practice here and the available facilities are very different. And so I think the expectations have to be different.
But I absolutely love that you are bringing advanced treatment options to the middle of Alaska, where we have struggled over the past few years. I've even flown a patient from Alaska to Seattle to get advanced care over at Swedish to save her leg. And now I know that you're there and we can help with, you're going to have to help me if we need a dog sled or something to pay to get the patients wherever you are. But
It's
we
actually
are
been a,
happy to help with transportation.
it's been an amazingly rewarding practice up here because
Yeah.
people come in from all over the state. They fly up to see me in Anchorage, and they see me in the office on Monday, and then get their procedures during the week, and then go back home. Interestingly, because it's such a vast area, most insurances will pay to have patients flown
Oh,
to
great.
urban areas uh, to get treatment. Yeah, and so they'll often come up with a family member, stay in a hotel, and get treatment and go home a few days later.
We have quite a few patients with PAD that are eager to ask you some questions. So I want to get to Heinz. Heinz, go ahead, and then we'll call on Marcia.
Hi, Doctor. Thanks
Hi,
for
good morning.
talking with us. Curious.
That's a beautiful background, Heinz. Where are you?
Colorado Springs.
Beautiful.
Yeah. That's Pikes Peak, by the way. You said you went off of statins to Repatha. Did you have side effects from the statins, or?
Yeah, I did. I had a lot of muscle cramps that bothered my legs and my lower back, and then my hemoglobin A1C started to go up. I eat really well. There's no reason for me to have anything related to sugar metabolism changing. And then my hemoglobin A1C started to creep up, and I said, this doesn't make any sense. And so I changed to Repatha.
Did they do any blood work to determine that it's from the statin, or did they just say, let's try this versus your current statin?
I mean, I've been on statins for probably 30 years, 25 or 30 years. And so originally it was simvastatin that gave me muscle cramps, and we did creatinine kinase, I think it was the muscle enzyme that was elevated. So then we went to Crestor, and a low dose Crestor didn't bother me, but low dose Crestor didn't control my lipids. And so as I changed to higher dose Crestor, then I got a lot of muscle cramps. And for someone who's very active, it really absolutely limited my life. And I say, how come I can't hike my normal 5 or 6 miles? Because my thighs are killing me. They shouldn't be killing me.
Okay, thanks.
Sure, thank you for asking.
Thank you, Heinz. And Marcia, go ahead and unmute.
Hello.
Hi,
Hi.
Marcia.
Hi. I actually have 2 questions. The first one is, when you were talking, you said you used the term fix it and fix things. And, we've always been taught in the group that you don't really fix it. You just, help blood flow so that you can walk more. So I'm curious if you could explain kind of what you meant there.
So meaning
I'm not sure exactly what I said.
Fixing the blood vessels, it's she's asking, so there's no cure, right? So fixing the blood flow does not equal cure. Fixing it meaning that we're going to eke a little bit more blood flow right now, because one of the things we always tell patients is these procedures are not a cure. It's not in place of your walking. The reason you have a procedure is to heal a wound and to ease the pain so that you can walk, build those collateral vessels. So when those procedures, fail, when the bypass goes down, when the blood vessel closes back up again, as it restenosis or the scar tissue builds up, you will have maybe built enough collateral vessels that you might not need another procedure. So that's what she's referring to.
I do think that if we change the risk factors, change the things that cause our peripheral arterial disease, risk factor reduction, that is, stop smoking, stop chewing tobacco, get your sugars under control, in my case, get my lipids under control, I do think that it stabilizes the disease to a place where I hope I never have to get this angioplasty again. I would like to think that these are more durable repairs instead of fixes. Repairs, more durable repairs. Although I won't be surprised if my heart disease comes back. I won't be surprised if these things come back. But I'd like to think that they're more durable with risk factor reduction.
Getting a little bit more blood flow so that you can walk further and faster, build those collateral vessels in, partnership with making sure you're on the right medications and your other, diet, no smoking, of course, but all of that together could literally stall progression is kind of that whole idea.
And the development of more and different medications is really ongoing. I mean, as Heinz asked about statins, and for me, statins were state of the art for years. That's what I took and believed to be the best. I didn't realize you can also change your cholesterol absorption and I take this shrimp krill or something that changes the amount of LDL that's absorbed, but my LDL levels are really low now. So that's, if I believe in science, which I do, can't say I believe in all of science, but I believe mostly in science. If I believe in it and I live it, I think I'll do better.
And what's your other question, Marcia?
Sorry. Yeah.
Marcia, what's your other question? Or did you ask it? I'm guessing she asked it. We have another question that's coming in. Sorry, we have our Lifesaver hotline that if you can hear on my computer, it keeps ringing and ringing. We have our pad navigators that are answering our Lifesaver hotline right now, but I do get the Lifesaver hotline that every time it comes in, at least it rings on my screen so I can see that people are calling in. So that's if you hear that in the background. Over and over again, we have quite a few calls coming in the moment. And usually when we are live, we end up, because the Lifesaver hotline is up here in the corner, we do get a lot more calls during our broadcast that my team ends up having to juggle in the moment. So, but we do have a question that's coming in just about those statins, because in our groups, everyone's talking about statins and whether they should be on statins. And I'm curious, with your experience on statins, how does, this patient wants to know how your experience with having the symptoms, the leg cramps and such, how does that help you to better understand the patient experience and to switch them to something else when they're expressing these types of symptoms? Because this person doesn't feel like her doctor listens.
I think that the evolution of lipid treatment has just changed in the last 10 or 15 years. And, we're old. We don't always change. And so your doctor may not be up to date with lipids. In fact, me and my nurse practitioner are going to open up a lipid clinic in our town because nobody treats lipids aggressively in the town that we treat in. It is way more complicated and tedious and probably not very remunerative if you're in private practice. For my personal experience, I knew that statins bothered me and gave me muscle cramps, and I have had lots of patients complain about it. So I just started to look into it more, and I didn't know until I looked into it rather recently that it drives up your hemoglobin A1C in a lot of patients who take it for a long period of time. I think that a lot of physicians listen to patients that complain as we go through, becoming senior citizens, and we have lots of complaints. And it's hard to differentiate muscle complaints from aging complaints. And so I think that a lot of people get blown off. And my personal experience was when I got off statins, and this is my personal experience, that it took about 3 months for the muscle cramps to really resolve and go away. And then my exercise tolerance really increased and really got a lot better. And I think that's why I ended up deciding that it was claudication that was bothering me, because I was so held back first by heart disease, which I was didn't realize that's what was slowing me down. And then by the statins, which really slowed me down. And once I got off the statins, I said, oh, it's not my thighs that are hurting me anymore. Now it's my calves that are bothering me. Oh, okay. And that's how I got there. I don't know if that answered your question.
I think it did. And she'll come back if you didn't follow up. But we have another one that came in. She says, I listened to an interview the other day on your YouTube where a vascular surgeon said she doesn't believe in checking the heart without symptoms for PAD patients. One, did you have symptoms noticeable before your heart cath, like angina, and two, do you now have every patient with PAD get their heart checked because of your situation? Because we're told to walk, walk, walk. And what if we walk, 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 increase our pace and we drop dead? Pretty direct.
In my individual case, I had asymptomatic, quite bad heart disease. I could walk hike 12 miles. I could ski. I could do lots of stuff that kept me very busy and that I liked to do. I knew that I got breathless when I skied hard. I knew that I got breathless when I did other things, and I blamed that on my beta blockers because my resting heart rate's around 45. So I was asymptomatic. Even when I had my coronary cath, I was almost all the way awake. And when they totally occluded my coronaries, when they were ballooning them, I was asymptomatic. And so I've always had patients see a cardiologist if they have leg disease. They should be checked out. And the thing is, when we see a cardiologist, people have different types of tests. And the guy that I saw was very clear that he wanted me to have a functional test, which is a stress test, rather than to have a anatomic test, which is a heart catheterization. In fact, I didn't want a heart catheterization, so I was going back and forth to Washington, D.C. at the time, so I went up to Baltimore, where Johns Hopkins had gotten a new CAT scanner, and their CAT scanner was the state-of-the-art thing and could do a heart CAT scan in 45 seconds or something. So I went up there and got a heart CAT scan to look at my coronary arteries, and they underestimated the blockage. So yeah, I think most people, if they have peripheral arterial disease, they're going to have coronary disease. It's all the same disease process. They're all small blood vessels.
And I think that's so important. And I thought that was a really important question that they asked, because we tell every one of our patients that if you're being told to walk, you need to have a cardiovascular evaluation. I know from experience, even with my dad, that he didn't have the typical angina. And thank goodness I had just interviewed one of the top CTO crossers. He's an interventional cardiologist out of Chicago. And he was saying fatigue is the new angina. You need to listen to that fatigue. You need to, if you're slowing down, if you're a little short of breath and you just are compensating for it, thinking it's old age, no, that's the new angina. You need to get in and get those things opened up. And, my dad, he was just on the verge of a heart attack. And he called me and he said, Kim, I walked up 2 stairs just now and I'm out of breath. This is really weird. He was on the table the next day. His right coronary is 95% blocked. And so
wonderful that they got that. Yeah.
It's incredible, but I'm seeing this over and over again. We just had one of our friends in our network who does half marathons, and he's 82, 83 years old, I think now. And he literally had grown so many collateral vessels, he had no right coronary. But because he exercises so much, it was literally his body had gotten him to a point to where he was on the verge of a massive heart attack, and he could only have a huge bypass procedure. You couldn't get the wires through at that point. Why can't we solve this sooner? 3 in 5 people who suffer a heart attack have PAD. We need to check. We need to pay attention to those legs, I think, a little bit more, right?
Absolutely true. Well said.
And so you have a procedure coming up. Would you mind walking us through the day that you have chosen for this procedure? We know you have chosen Dr. Amar El-Sergani. Hey, I've let him touch my legs too. I mean, he's really, I've seen what he can do. He works magic. He's saved so many of our patients that, other surgeons have said there's nothing possible. And he's been able to go in and work his magic. So I have full faith as well in his skill set.
So he and I have a similar surgical style, and so I like that he has the same approach that I normally take. For me, I'm going to be working. He has several offices, and I'm going to be working at some of his outlying offices, which sounds wonderful. One is in Kona, so I'll go down to Kona a few days early and vacation there, and then work in the office, and then I'll work in his main office down on Oahu. And then when my procedures are done, I'll get when I finish taking care of the people that day, then I'll be his last patient and get my legs fixed.
Oh my goodness. So you're going to be working all day in the cath lab and performing procedures, and then you are going to turn around and get on the table.
Yeah, I guess it doesn't sound quite right, but that's what I'm going to do. That's the plan.
Well, hopefully we're going to be right there. We're supporting you. We want to keep hearing from you. So many patients, want to, you to continue to come back, share your experience. We would never wish PAD upon anyone. It's incredibly debilitating. But there's so much comfort in knowing that there is a doctor who treats PAD that has it and who understands. And we really appreciate you coming here and bringing your perspective and sharing it, your understanding with patients of what it's like.
Sure.
I
think that I'm listening to what I'm saying to you. I think the context of the fact that I'm going to be working that day and then having a procedure also should reassure people of the context of, for the people who do this every day, how we don't see this as a huge deal. Okay. It's not taking a little thing off your body, a skin biopsy, but we don't see this as something that you have to prepare for. And oh my God, I have to worry about this. I have to worry about that. It's quite routine, although it's very, very important for us who do this every day. This is a very routine thing. We do hundreds of these things. And when you go and have a procedure, you're there and there's 5 or 6 or 7 people taking care of you simultaneously. It's not like you're there alone. And they're quite safe and they're quite routine, even though they're dramatic. And I expect that I'll be fine, go home and say, oh my gosh, I should have done this a long time ago. And I'm really excited to get back and go hiking and see how far I can go.
I mean, this is really comforting to hear that you are a general and vascular surgeon and this is your perspective, because there's still a very large contingency of folks out there who treat PAD that think there are too many of these procedures being done and you shouldn't do them in lifestyle limiting claudication. You should only wait till there's a wound. And these patients are just suffering and suffering. And they say, I mean, and I'm only telling you because this is what I'm being told by some of these, doctors that are resistant to treating sooner rather than later, that the risk outweighs the reward with these procedures. And why delay the inevitable? Why treat below the knee? It's just going to lead to a revolving door of procedures. So let's just, either 1, walk until you have too much pain and we'll amputate, or 2, let's just go ahead and amputate and why delay the inevitable?
I think there is an evolution of care that's technology related, it's age related, it's awareness related for programs like yours that make people aware that there are other options. And in most places, you can go to another physician in your area, or, even if it's 25 miles away, as I say to people, you'll drive 30 miles to go to a good restaurant, but you won't go an extra 5 miles to go to a different doctor that you have more confidence in. And I think those are choices that we can all make to get better care if it's available in your community.
You use the example of restaurants. I use the example of cancer care. And I have patients that will literally drive hours and hours and hours to a center of excellence for cancer. But when it comes to their PAD and the doctor's offering a major procedure, or, whether it's bypass or amputation, they won't drive a couple of hours to an advanced limb salvage surgeon that might have a more minimally invasive approach, which allows you to then kick the can further, because some of these major procedures, such as amputation, well, that's permanent. Some of these surgical procedures, well, what is the contingency plan when that bypass fails? At least sometimes with a minimally invasive approach first, you can kick the can forward a little bit more, have time to mitigate those risk factors. Because if you don't mitigate those risk factors and you have a major surgical bypass and that goes down, well, you're screwed. So why not start a little bit slower, do a less is more, get those risk factors under control, take your medicine, take your diet seriously, start that walking routine, quit smoking, and then let's see how you do. And especially those with clotting disorders, right? So important to get that under control.
Yeah, that's really well said. Yes, absolutely true. Mm-hmm.
Well, Dr. Lurie, we really appreciate you. We're excited to have you back. I know you and I talked about doing something regular, so everyone needs to stay tuned because we have something special, although we haven't quite come up with it yet, planned ahead to do something regular where Dr. Lurie is going to be available to share his insights and answer your questions more routinely, I think. But we're going to follow your procedure. It's next week, and we'll check in with you to see how you do, which I'm sure we're going to see you. We're going to see you meeting, I think, with Heinz, maybe at Pikes Peak over there and hiking that.
Awful great.
It's only 14,000 feet.
It's only 14,000 feet.
There we go. Thanks so much for your time, Kim.
Appreciate it. Thank you, everyone, for joining us. Make sure you like the video, subscribe to our channel to get the updates. Click on the notifications button to make sure you stay up to date and follow Dr. Lurie's journey. Thanks, everyone, for joining us.